Hello dears, this is my second lecture uh, after the new classification of periodontology. I am Dr. Harim Jafar Hamad Rashid, lecturer at Periodontal Department, University of Suleiman. So today I'll talk about periodontal flap and suture technique. This is actually two topics, but I want to simplify it for you in one single point or one single lecture. So my agenda simply is talking about the flap procedures and second incisions and then suturing modalities. Actually, the flap procedures, we are talking about four topics: the goals and designs, classification, and types of incision. Our goal in the flap procedure is to increase the accessibility to root deposits. For example, when we are doing subgingival root planing on daily basis, it's a closed procedure. But when we are doing a flap procedure and we are opening the area, we increase the accessibility, we increase the view to the root deposits, and we can access the area very easily. And it will eliminate or reduce the pocket depth. This is the second goal. And thirdly is to perform regenerative methods like grafts, soft tissue and bone grafts. So we have accessibility, elimination of pockets, and regenerations. These are the main goals. We have features of flap design. One of them is your flap should have a wider base. The base of the flap should be wide, and you should avoid vital structures like arteries and nerves. Thirdly, the incision over intact bone, not a defect or eminence. You should do your incision on the sound bone, not on the cyst. For example, if there's a cyst and you want to remove it, you can't do a flap design across the cystic lesion or across an area of defects or bony defects, or it's forbidden, or you can't do it, your incision on the canine eminence or any eminence inside the oral cavity, because it will tear the flap and make it difficult to be replaced into its position. The vertical incisions should be at line angles. Then we should have a post-operative plug control for every flap procedure. When you open a flap and close it, you should instruct your patient about the post-operative plug control. So according to the classifications of the flap, we have three classifications. Based on the flap placement after surgery, we have displaced and non-displaced flap. The displaced flap is when you move a flap from one place to another. For example, you want to cover a recession and you need an epithelium. So, for example, you coronally advance the flap toward the crown. This is displaced flap. Or sometimes you are here, you have a pocket, pseudo pocket, and you want to reduce the depth of the pocket. You apically toward the root displace the flap. So in this case, it's also displaced. But non-displaced flap, when you rise the flap and close it on the same position, this is the non-displaced flap. This is based on the flap placement after surgery. Based on bone exposure after reflection, we have full thickness or mucoperiosteal, and we have partial thickness or mucosal. In case of full thickness, we elevate the epithelium with the connective tissue, while in partial thickness, we elevate the epithelium and part of the connective tissue. So part of it with the periosteum remain on the tooth surface and on the bone. So in these cases, it depends on the type of exposure. For example, when we need to put a free gingival graft, we need to put an epithelium. We need a blood supply. We need a connective tissue. We can't fully elevate the flap and put an epithelium on a bone without a source of blood supply. So in these cases, we need a partial thickness flap. While when for example, in case of connective tissue, we should do a full thickness flap and put in a connective tissue and applying the flap on its position. While based on the management of papilla, because the papilla is a crucial aesthetic part and sealing part of the gingiva or the periodontal compartment, so in this case, based on management of the papilla to the conventional and papillary preservation. Conventional, usually we just elevate the flap with the attaching the papilla like this. For example, we detaching in the middle both the palatal and buccal papilla. And then we are placing it after that into its position. While in papillary preservation, when we need to preserve a papilla, for example, in some kinds of regenerative therapies, we need a papilla for in these cases, for example. So we do an incision. For example, this is a papilla between the upper centrals. We just do an incision palatally on the base of the papilla palatally, then release it and push the papilla, the palatal papilla, with the buccal or labial papilla outward, and do your works. For example, putting a bone graft or soft tissue grafts or connective tissues. Then you are putting, like you see it here, then you are putting it inside, and the papilla will be without cut and into its exact position. So we just have conventional and papillary preservation according to the papillary management. The types of incision, we have two types of incision while elevating the flap. We have a horizontal incision and we have a vertical incision. There's a rule: we shouldn't do a vertical incision in the palatal side. The palate, you shouldn't do in the palate, and also on the lingual surface of the lower, you shouldn't do any vertical incision, because it's difficult to stretch or displace the flap palatally. So I think it's forbidden to do any vertical incision palatally. Regarding the facial vertical incision, shouldn't be made in the center of the interdental papilla or over the root surface of the tooth. the incision shouldn't be, the vertical incision shouldn't be in the center of papilla and exactly on the root surface of the tooth. Vertical incision must extend beyond the mucogingival line. You shouldn't do a vertical incision just on the attached gingiva. It should extend to the mucosa to make it to be able to displace the flap in case you need it, and to put it on exact position. Vertical incision in the lingual and palatal areas, as I told you, are avoided. Incisions should be made at the line angles of a tooth, either to include the papilla in the flap or to avoid it completely. So you should do it at the line angles of the tooth, and could be used on one or both sides of horizontal incision. Sometimes we do a one vertical incision, and sometimes we do on both sides of the horizontal incision. We do two vertical incisions, and as you see it here, this is wrong. Why? Because it's on the root surface. Okay, and this is wrong. Why? Because it's in the middle of the papilla. This is at the line angle, at the sides of the tooth, mesial or distal side, beside the middle area of the papilla. Look, not at the middle. This is incorrect, these two, and this is correct. Either on mesial or distal side, but at the line angles. While types of horizontal incision, we have the internal bevel incision, as you see it here, the A, which starts at the distance from the gingival margin and aimed at the bone crest. You just pass a few millimeter, 1 to 2 millimeter, and directly applying the blade on the bone, in going through the free gingiva directly on the bone. So this is the internal bevel incision. While the crevicular incision, which means the sulcular incision, you just put the blade inside the sulcus till the bone, and this is named a sulcular incision or crevicular incision. While interdental incision is performed after the flap is elevated. You elevating the flap, and the piece that remained from the internal bevel incision and the sulcular incision, this incision to remove this part is named interdental incision. And we have, for the pocket management, we have undisplaced flap, apically displaced flap, modified Woodman flap. We talked about the undisplaced flap and displaced flap, or apically repositioned flap. For example, sometimes you have a swelling or a false pocket, gingival swelling, and you want to reduce this false pocket. So you put it apically. It's on the tooth surface, it's coronally. So you displace the flap apically. This is named apical reposition flap. One of its aim is to reduce the pocket depth. And also we have a modified Woodman flap. The modified Woodman flap, in this case we have a conventional type of flap opening both in the palatal and the buccal sides. Then you remove the necrotic cementum and the dead tissues. You clean it, and after that you just put the flaps both palatally here and buccally on the same position, and you suture it. This is modified wooden flap. These are used for pocket treatment. We have undisplaced, we have displaced, like apically repositioned flap, and we have modified Whitman flap. In case of suture modalities, we have many techniques. The most important one are simple interrupted. In case of simple interrupted, you have 2 points. You have the entrance point, you have the exit point, then you tie the sutures. This is simple interrupted. While in case of horizontal mattress, you have 4 points. You have 4 points of attachment. First of all, this is the first one. For example, when you hit the first point, you go inside, okay, then you exit on the other side. For example, this is 1, this is 2, okay, and this is 4, and then you tie the suture. So you have 4 points, 1, 2, 3, and 4, okay, and then you tie the suture here when you start it. Okay, so this is horizontal mattress. This is used for a large area or a wide area of incisions to be covered. We are using the horizontal mattress. While vertical mattress, no, there's a figure 8 suture. Maybe the next slide will be vertical mattress. Figure 8 is used to cover the extraction area. Okay, you have 4 points. You insert from one area to the opposite side. Then you start from the same side of the first point. So this is 1, this is 2, then go to the other side, do the other entrance, then go to the other side, doing the other entrance. So you have 4 points, 1, 2, 3, 4, and you just tied your knot here. This is X suture or figure 8. Well, in case of vertical mattress, which is used for deep wounds, in case of deep wounds, we have 4 points also, but in another manner. For example, we do a deep cut. For example, here, a deep cut with the needle. This is first point to the second point, deep and far from the edge of the wound. This is the edge of the wound, far from the edge and deep inside. So far, and from here we do a near and near the edge, and superficial, near superficial, and do your tie here. This is used when many areas or deep tissues are involved in cases of incision or traumas. And also we have a sling suture. This is very important in cases of putting a graft or in some kinds of mucogingival surgeries. This is simply you put the needle or insert it, for example, on this side, and when you come to the palatal side, for example, or lingual side, you doesn't, as you see it here, you doesn't put the needle inside any tissue. Just wrap it around the tooth, and you exit on the same buccal side, okay? and you hit the buccal side, okay, and go to the lingually without hitting any tissue, then hitting the buccal side as you see it here, then going and going without hitting the lingual side, just hitting the buccal. And when you reach the end, then you start to wrap it around the buccal side without cutting it, then insert it as you see it here, insert it on the lingual side. Then when you come from backward to the first position, then here you just wrap it oppositely as the first position. You wrap it on the lingual side, insert on the lingual side, and wrap it on the buccal side. Insert it on the lingual and wrap it on the buccal. Insert it on the lingual and wrap it on the buccal. Then after that, you reach to the first point as you started. And when you just pull it, every tissue stays tight and remain in its exact position. So these are the types of suture simply, and we may have videos on this on the YouTube channel. I hope you visit this channel named Dr. Halim Jaffer. This is regarding lectures, your lectures, and clinical cases. I hope you will get benefit from it. Thank you for listening. Have a nice day.